Good morning, ladies and gentlemen. I'm very pleased to be here, although I now see myself challenged with a piece of technology that I don't normally use, but I will be using during the course of this speech. I'd like to thank TASC, the Adelaide Hospital Society, and the Jesuit Centre for Faith and Justice for their invitation to speak to you at this important conference. And indeed, just listening to Nat and his opening remarks, I read the spirit level, and there's much in it that I would agree with. And I think you will find from what I have to say to you that certainly as a Minister for Health, we're trying to address health inequality and end what I've always been extremely unhappy with and uncomfortable working in, a two-tier health service. I'm sorry I was late arriving, but they held me up in News Talk a little bit longer than was agreed. But I was very happy to do that interview this morning and emphasise the fact that we will end the two-tier system, that we will bring equality to our health service, that we will have a service that meets patients' needs and based on their needs, not what they have in their wallet. So I suppose to go into the speech proper, I start with the old joke. When you're up to your what's it in alligators, it's hard to remember you went in to drain the swamp. And by God, are we in a water infested with many alligators. And in health service reform, there's an awful lot of alligators, but we're as determined as ever to drain this swamp. Just some of the challenges that face us. This year alone, 750 million has had to come out of a health system that's already lost 1.75 billion in the last 2 years. And we're also losing people, as you know, huge reductions because of retirements. And all this in the midst of demand for services ballooning because we're incredibly fertile as a nation, higher rates of fertility than any other EU country. And at the other end of the continuum, we're living longer, thanks in part to our health services. And I think it's great that we have an ever-increasing younger population. So is this a good time to take the system by the scruff of the neck and reform it, with these sort of challenges looming in front of us? I absolutely believe it is. And out of the greatest of challenges come the most wonderful of opportunities. And just to remind ourselves maybe of some others not too far away who did similar things, Britain's National Health Service was set up on the wreckage of the Blitz. Many of the major breakthroughs in surgery came from the battlefield. We learn from bad times, and a radically improved health service will come out of these bad years. Of that I am determined and sure. But reform of the health system is not enough. It must be the right kind of reform. Globally, most healthcare reform programmes have failed to deliver the kind of changes their authors hoped for, and as a result it fails. And I've made the point time and time again, and I make it again here this morning, no matter how clever or elegant a strategy is or a new policy is, if it doesn't improve patient care and the patient experience, it's not worth the paper it's written on. Part of the explanation of this is that healthcare reform tends to be piecemeal rather than comprehensive. It focuses on just one part of the system and largely ignores the rest. Our approach is very different. It's built on 3 key pillars. But as everybody knows, no part of the health system exists on its own. You cannot fix your emergency department problem without addressing the issues that occur in primary care, or the inpatient bed problem, or the outpatients, or indeed the long-term care requirements, home help, care in the community. All of it has to be addressed at once. And that's why we're not going for piecemeal. We're going for, yeah, you can call it the Big Bang, I call it holistic, comprehensive. And this time we will succeed. But first we have to change the care model. And I mean, it's important to remember that up to 95% of people's day-to-day health and social care needs can be met in the primary care setting. And that's where we're headed, and it will require new models of care across all service areas, treating patients at the lowest level of complexity and providing quality services at the lowest possible cost and as near to home as possible. And secondly, a new money follows the patient financial system that will incentivise providers to produce high quality care at lower cost. Right now, every additional patient is a cost to the system. There's no financial incentive to do more, to do better. And in many ways, the incentive is to do less. And why do I say that? Well, if you give a hospital a block budget for a year and it costs them €1,400 a day to have a patient in that bed, you'd imagine they'd want them out as quick as possible. However, if the new patient coming in is acutely ill and it's going to cost them £5,000 a day, is there an incentive? We need to change that. And not alone will that change the incentive, but it will put the patient centre, because simply put, if there's no patient, there will be no payment. And that's what this has to be about the patient first, middle and last. So the third thing we want to do is a major reform of the structure of the system and an end to the hugely over-centralised command and control model of healthcare that has disempowered the front line, reduced accountability and obscured any transparency. So if we want accountability, we first of all must have transparency. We must have information. And of course, all of this, as I said at the outset, must be built around the patient, because that's where it starts and that's where it finishes. All the structural changes are about that, about kicking away those aspects of the system that don't put the patient at the centre. All the structural changes about getting patients treated at the lowest level of complexity instead of huge populations headed for acute hospitals when their conditions are better treated or might have been avoided altogether by prevention in primary care. All the structural changes are predicated on one reality. People who choose to work in healthcare are special. I know there are many here today who do. They went into this profession of either medicine, nursing or other aspects of care to save lives, to improve lives, to help people. And they deserve systems that support them in their mission. Now, we've been accused in the past of not having a plan, or not being clear enough in our plan, or not having a clear direction of travel. We're very clear, and I'm going to share some of that with you here today. The ultimate goal is clear. It's a single-tier health system by 2016 underpinned by universal health insurance. A system where everyone is treated equally, where the needs of the patient and not the size of their wallet is what counts. The programme for government commits us to deliver a multi-payer model of universal health insurance underpinned by a public option. Now, I say that word carefully. That debate is over. Government policy is a multi-payer model of universal health insurance. Our goal is not to slavishly introduce the Dutch model of healthcare, although it has real strengths, or the German model or the Canadian model. We take what's best from all of them and create a truly Irish model of healthcare which meets the needs and requirements of our people. So we looked at the North. In his introduction, Matt very kindly talked about many of the things I've done, like wearing previous hats in a different career. One of them, however, wasn't mentioned, and that is that I was the Irish representative on the World Medical Association for many years. I had that privilege and honour, and it afforded me the opportunity to look at many different health systems around the world. So when we went about defining our health policy, we looked in many different jurisdictions, and we took what we thought was best for us and modified them to our situation. So this isn't about the Dutch model of care. This is about a special delivery unit that came about as part of a waiting list initiative in the north of Ireland. It's about a plan to have networks of hospitals based on the English model of trusts, not mimicking them, but modifying it to the Irish situation, and looking at patient safety and a patient safety authority, looking particularly at places like Denmark and Canada. And yes, we've looked at the Dutch system as well and saw what we liked about it, and we will modify that to our system. I think one of the things that concerns people is personal budgets. We have no notion of mimicking that system that's there in Holland. Ours is a very different type of personalised budget that we're talking about for people with disability. So I have one slide here which lays it out. It's kind of difficult to read, I guess. If I can work this. No, wrong one. That's it. Let me just talk you through that. At the centre was the creation of the Special Delivery Unit, and I will talk about that in a moment. This year, and that was 2011, this year we have the 4 key reform priorities. And these include delivery of the SDU's agenda, changing the model of care, overhauling the system of governance, and reform of the insurance sector. And a critical part of that governance is the directorates. And we have the legislation coming to Cabinet shortly, heads of the bill to allow us to create new directorates, of whom there will be 7. Hospitals, primary care, social care, mental health, children, public health and shared services. And why is this important? It's important because we never had clarity of where our money has been going. The Fair Deal fiasco last year demonstrated that very clearly. Money put aside, voted by the Oireachtas as representative of the people, taken down into an organisation and then distributed in a different fashion. Of course, for care of elderly, but not for long-term care, which it was specifically designed for and voted for. And we had previous episodes of this where we had a situation where money put aside for mental health and for palliative care was subsumed into the general budget and used for other reasons. That's not acceptable to me. I want transparency. I want the hard-pressed taxpayer of this country to know where the money's gone, who spent it, and why they spent it. We get our accountability. And isn't it extraordinary that nearly half our staff in the health service work in the community, and yet we had no national director for primary care? That's all going to change. This makes it very clear. And mental health, which has been the Cinderella of our services, again, in the past, ignored. That will not happen under this government. So if I can just move along to the SDU, as I mentioned earlier, it's an initiative we borrowed from Northern Ireland. Our approach to hospital trusts is based on an English model, as I said, while the Patient Safety Authority is based more on the Danish and Canadian models. Now, I know that there are some who will say and argue that we're being too ambitious. The potential opposition is too great. Well, I'm here to tell you that reform is already working, and that far from slowing the process down, we intend to accelerate it. And to remind any who might have other ideas that this government has a massive mandate from the people to do this, to bring in universal health insurance. Both Fine Gael and Labour were returned in unprecedented numbers by the people of this country, and health policy on both of our parties is very much focused on this area. So not alone can we deliver it, we will deliver it. And let's look at the example of the Special Delivery Unit. It was formed in June. In September it became operational. In August of last year, just before the SDU started working, the number of trolleys in emergency departments was up by 30% compared with the previous year. 30%. So we were heading in the wrong direction, and we were heading for a winter crisis, but it didn't happen. The Special Delivery Unit cut the number of patients waiting on trolleys in the first 2 months of this year by 17%. And you can see from the next slide, which is one of my favourite, it shows that from the time they became active, numbers started to drop, and by mid-December, numbers went below where they were last year. And we've consistently maintained that. If this slide continued on to today, it would show, on average, 17% lower than the line above. So, of course, it would follow the other line, but much lower than it. And we have more initiatives on the way to address this. But I want to make this very clear. The Special Delivery Unit succeeded because it listened and it analysed. And Dr. Martin Connor brings that strength, not just of his own analytical mind, but of the many contacts and connections he has throughout the academic world. We've been able to analyse what's happening, see the reasons for it, and then consult with the front line, who've come forward with their views, with their suggestions. And then the clinical programmes cooperate to put in place safe protocols to ensure that the service is delivered safely. So everybody has worked together on this, and for the first time, I believe, the front line is beginning to feel empowered, and the system is starting to believe that it can fix this itself. Because up till this, billion after billion was thrown at health, and people just threw their hands up in the air. Nothing seemed to work. So what's the real message there? The real message there is that money could have solved this problem, it would have been solved years ago. But money is not the answer. It's surely part of the answer, but the real answer lies in reorganisation, how we do our work, how we're organised, how we deliver it. And that means a lot of change for a lot of people. And I'm very pleased to say that a lot of people have started to come to the party, and that new leadership is beginning to flourish, and people are taking things into their own hands in the sure knowledge that they will be listened to. We don't always agree with everything we're told, but we will listen and we will analyse. And if that makes sense and it's value for money, we'll do it. And I think Drogheda was a great example of that. It wasn't just a case of a few more medical beds, it wasn't just a case of more long-term care, it was also a community intervention team so people could have their IV antibiotics at home. It was about more help, more home care packages. It was about a range of initiatives suggested by the hospital themselves about longer working hours in the medical assessment unit. So I know the critics will say, yeah, well, look, sure, it's only, 17% down, and, well, sure, didn't you have a mild winter, and sure, there wasn't much flu around. Sure, it was easy, really, wasn't it? Except that the number of people attending accident and emergency departments was actually up in those months on the previous year. So the SDU, as I say, drilled down into the figures, asked the awkward questions, stayed on the case every hour of every day, and delivered the goods. And like I say, they did not do it on their own. The system did it. I gave them two immediate priorities in the special delivery unit. First was the trolley issue, and once we've made progress, I want to move on to real-time patient experience. The new target is that all patients will be discharged or admitted from the emergency department within 9 hours of registration. And this should be 6 hours for 95% of those who attend. And I want to tell you a little funny incident. The backbencher from Labour approached me 2 days ago and said it was outrageous. He was incandescent with rage. There was twice as many people, 200%, on trolleys in Portiuncula than there was in Galway University Hospital. 200%! There was 2 in Portiuncula and 1 in Galway University Hospital. And yesterday, for the first time in living memory, none. That's the new management, that's the new team, that's the new leadership emerging. That's everybody pulling together. Now, I don't know how well we can sustain that level, but that gives fantastic confidence to the doctors, nurses, and all the staff working in that hospital. And I do like to make this point when I visit hospitals, and I visit 16 of them in a matter of 2.5 weeks to ensure that the contingency plans in place for the retirements which took place at the end of last month would not lead to serious risk for any of our citizens. And I found this new energy and a new belief in themselves. And I think that's something we must encourage. And I said to them all that we're here to support, not to beat you over the head. And we will support people who want to take risks in terms of new things, new change, new ways of doing business that will lead to better patient care and better outcomes for patients. The second key priority I gave the SDU was in relation to scheduled care. I directed all public hospitals to ensure that they had no patient waiting more than 12 months by the end of 2011. They took action, and at the end of 2011, 41 hospitals, or 95% of the total, met the target to eliminate over 12-month waiters from their active list. Now, in the opening remarks, we talked about equity. And I have to say to you, I make no apology for insisting that those who wait longer should be treated first. And I do also qualify that by saying that, of course, cancer cases, of course, urgent cases are always treated outside of this initiative. They're not part of the chronological order. They're looked after immediately. They always take precedence. But when it comes to long waiters, those who are waiting longest should be treated first. It's not fair that people are left waiting 1, 2, 3 years. This year, the target is 9 months. Now, I mentioned 41 hospitals. Only one area didn't succeed, Galway. And the reasons for that were obvious. And that's been addressed now. So I think that puts into perspective the great work that Bill Maher has done down there and all the team. Now, as I say, we want to move to a 9-month maximum waiting time by September 2012. So you can see, it's only small, it's only incremental, but reform is working, it's real, and it's measurable. The other thing I wanted the SCU to do in 2012 is to begin the work to transform public hospitals to independent hospital trusts. And the first step is setting up of initial hospital groups, and work on this is beginning immediately. In fact, it's well advanced. The hospital groups will have a single clinical governance model, one budget and one employment ceiling, and that's what we did in Galway. We gave Bill Maher as the new CEO over Galway University Hospital, Portiuncula, Merlin Park and Roscommon. And he's got his own budget and he can make his own decisions. And I've made it very clear to him that I want to see movement of work out of the bigger hospital to the smaller hospitals. I mean, this week, on Monday, I opened a health research facility in Cork, and I was at an Irish Medical Devices meeting yesterday, 7.2 billion in exports, employing 25,000 people. We have to support research. It's the way forward. But I made this point. We also want research in what was alluded to by Nat earlier in terms of organisation and delivery. I mean, Dr. Susan O'Reilly, who heads up our National Cancer Control Programme, has shown very clearly from research that improvement in management and organisation can deliver a 10% increase in better outcomes for patients. 10% improvement in morbidity and mortality. Just through organisation, not through medication. So we've got to pursue that end of things, and even though we've done a lot of research, we'll be doing a lot more. We have to make more use of the smaller hospitals. And the reason I mention technology is because we have had a row about what we've had to take out of smaller hospitals, which wasn't safe. But wait for the row that comes now about taking the stuff out of the bigger hospitals that shouldn't be there and that should be in the smaller hospitals. And indeed, as technology moves, more stuff will go into primary care, to the GP. And as technology continues to move, as it has already, more stuff from the GP back to the patient, where it belongs. Why shouldn't our citizens have control over their own health? And if technology allows that and affords that, that's where we're going, ultimately. And leave these super specialised tertiary centres the room to do that super work that they do and can't be done anywhere else. So I've often made the analogy of the 10-year-old Volkswagen going up to the Ferrari testing centre for a service when the local garage could do just as good a job and does. So the new arrangements will simplify reporting structures and foster better management of the services regional hospitals deliver to patients, and the smaller hospitals, as I say, managed as part of a group, will have their role protected. And we will address a number of issues by doing this. We'll address the issue of recruitment, because every young doctor wants on their CV that they worked in the big hospital, the Mater, the University Hospital Galway, whatever. They don't want, no disrespect to Portugal, Roscommon or Naas or Navan. But if they're part of a group and it's Dublin North East Hospital Network and you rotate through all the hospitals, that looks good on your CV, and those hospitals get the service and the recruitment that they need. And equally for the senior medical personnel and surgeons. Those working in those smaller hospitals often can lose their skill set if they're not doing the major procedures frequently enough. If they're part of a larger group and they're circulating through, they'll maintain their skill set. Better for them and safer for patients. And that's what this has to be about again. It's not about small hospitals, it's not about primary care, and it's not about tertiary hospitals. It's about patients, citizens. Another critical aspect of the reform of the acute hospital system is the implementation of a new, more efficient funding system for hospital care, which I mentioned earlier. Under money follows the patient funding method, financial incentives will ensure higher quality and lower cost. And just to give you an example of that, we introduced that in the last year into the orthopaedic sector. And I mentioned Navan, where nobody was coming in on the day of surgery. They were all been admitted the night before. When we brought in this incentive that we would pay you per patient seen as long as they were brought in on the day of surgery, unless there was some, really serious coexisting comorbidity, we'd pay you on the spot. And they moved from a position where they were doing with nobody to 80% in 1 month. Now, CAPA do vast numbers, and they increased their rate by 45% in a very short period too, and they saved us £6.5 million. And I come back to this, when I talk about saving money, I don't mean it's money to give back to the exchequer, I mean that's money that allows us to treat more patients more quickly, and that's what this has to be about. So we have the problem, and in my earlier slide I talk about insurance. And we need to look at the problems of the current private health insurance market, where insurers have a considerable incentive to cover younger, better risks rather than older, poorer risks. And I'm strongly committed, as the government is, to protecting community rating, whereby older and less healthy customers pay the same for the same cover as younger and healthier people. In order to protect community rating, we need a system of risk equalisation. Within the next few months, I will introduce legislation for a new risk equalisation scheme to come into effect from the 1st of January 2013. But in fairness to the insurers, I've made it public to them what the risk equalisation will be. So they have a full year to get their strategies together and to get their organisation to deal with the new regime that will be in place. And that will ensure that companies such as the VHI, with most of the older and less healthy customers, will be better able to compete on a level playing field. In the meantime, an interim scheme of age-related tax credits and community rating levy has been in existence since 2009 and has been providing significant support to community rating. I extended that interim scheme for a further year this year under the Health Insurance Miscellaneous Act. If this had not been done, the increases to older people would have been in the order of 17.5%. And they're the VHI's figures themselves. But it is the last year of it. In order to keep down the cost of health insurance for older people, I increased significantly, as I say, the age-related income tax credit for 60-year-olds and older from the 1st of January 2012. We have to keep the health insurance market as competitive and as affordable as possible. And yes, I acknowledge numbers have been falling, but the decline in private health insurance coverage is modest when you take the economic situation into account. The number covered has fallen by 66,000 in the last year, which is a big number, but it is a decline of less than 3%. Even in the current difficult financial climate, the vast majority of consumers with private health insurance are retaining some level of health insurance cover. Nonetheless, the government is concerned that private insurance is becoming harder to afford, and I am keen to explore any available measures to limit the costs related to health insurance. My department is also currently in the process of drafting the Health Information Bill to provide a legal framework for the introduction of an individual health identifier, and I know many people in this room will see that as a critical development, because it is an important step in patient safety and a useful component in the development of universal health insurance and universal primary care registration. In addition, the bill will have provisions aimed at supporting patient safety in areas of open disclosure, adverse event reporting and clinical audit. On the subject of patient safety, we mustn't forget that when quality, safety and public health issues are not to the fore in structural reform and reconfiguration of healthcare, they can sometimes be compromised. This must and will not happen. We're developing a patient safety authority and strengthening the culture of safety and quality across the health services, and this will be underpinned by the introduction of national standards for safer, better healthcare. They've been prepared by HICWA, the Health Information and Quality Authority, and should be approved before the summer. Once adopted, the application of the standards will be reinforced by legislation for the mandatory licensing of public and private healthcare providers. Later today, Dr. Tony Hoolan, Chief Medical Officer of my department, will be discussing in detail Your Health is Your Wealth, a policy framework for a healthier Ireland. The policy framework will be Ireland's vision for a healthier population that is protected from public health threats, living in a healthier and more sustainable environment with increased social and economic productivity and greater social inclusion. We want to see more emphasis on prevention, and we want to move away from what historically has been the case, which is paying lip service to it but not doing it. And we will take on the vested interests in relation to the tobacco industry and the alcohol industry and those who would advertise foods that are unhealthy to our children especially. And I am committed to labelling in restaurants of food, and that people know at least what they're eating and know the consequences and make decisions based on information. That's the least we're entitled to in a democracy. So, in conclusion, we're in a swamp, surrounded by alligators, but the clean-up has begun. We've made significant progress, like the reductions in people tally counts and the number of patients waiting over 12 months for operations. We've set in train a programme of health service reform that will be comprehensive rather than incremental, that will be led by innovation, not dictated by resources. And most importantly, it will be patient-focused instead of system-focused. So, ladies and gentlemen, we're on the move towards a much better place, a place where patients can feel safe and where health workers can be proud. And once again, I'd like to thank you for your invitation to address you here today. And I also want to thank the Irish people on the eve of my first birthday as a minister for affording me this wonderful opportunity to lead this reform. I know we can and will succeed because of the enthusiasm and ability of new clinical and managerial leadership that's evolving. And I'm very proud to have been part of that, and I'm determined more now than ever to see it succeed. Thank you.